Now, this head nodding syndrome is an emerging neurological disorder which is being described in quite a few countries. It's characterized by head nods with or without other epileptic seizures. There is a neurological deterioration with the development of multiple other disabilities, cognitive decline, growth failures, quite significant stunting, and stunted growth. It was first described in South Tanzania, and thereafter in South Sudan, in Uganda, and there are some case reports from Liberia. In Uganda, it is in quite a localized area, which I've marked red, and in the surrounding areas. The only thing which is strange, which is specific to this area, this is just one ethnic community. It's a Luo community, the Acholi sub-community. And this area is relatively flat with a few mountainous areas with two fast-flowing rivers. And like many other areas in Uganda and in sub-Saharan Africa, it's quite endemic for malaria and also for onchocerciasis. Now, the adjacent area in South Sudan which is affected is not just very close, but it's over 100 miles away, close about 200 or 250 miles away from this particular region. And to describe this condition, a case definition has been developed. One, for communities to be able to identify the cases being described as a suspected case, that any person, they are usually children and adolescents, with an observed head nodding, and then a probable case, because we do not have a diagnostic criteria, we do not know what the diagnosis is, so we have decided to call it a probable case, that a person with at least 2 or more of these episodes occurring spontaneously or occurring, most of them are associated with food. They start eating, and then shortly after they start with those episodes of head nods, and sometimes associated with a cold breeze. And often there is some other neurological feature, and including regression, development of motor disabilities, and cognitive decline. In 2009, when these reports first came out in Uganda, a community survey was performed. So the community health workers were asked to report any cases using that case definition, any cases they had in their villages. Most of our villages have at least 2 community health workers. And then these reported cases were then evaluated using the probable case definition. And from this case, it will appear that the first few cases may have started around the year 1998. And over time, the increasing number of cases have built up. The youngest age at presentation, at onset of symptoms, was 2 years, although the majority of them were in the age, by the time they were seen, the majority of them were in the age group of 8 to 15 years. Now, since February, we have undertaken quite a number of interventions. The first being to try to improve on the case definition, to develop guidelines for management, and then use these guidelines to screen the communities and try to offer treatment for these children. Because prior to that, they were on different forms of anti-epileptic medications, carbamazepine, phenytoin, phenobarb, really with no particular criteria. And using this, during this time, a few of us had spent quite a bit of time there. And classically, these children have these head nods. They are not just sudden head nods like in a spasm. It's, as you'll have seen, it's just a slow a slow head nod. And with the investigations we have had, these head nods are actually atonic seizures. During that, you see a drop, a loss in muscle tone. And so the early manifestations are not really well clearly described, but the parents do report that a few weeks before the onset of these head nods, many of these children appear not to be well. They have increasing inattentiveness and sometimes complaining of dizzy spells and being withdrawal. And several weeks later, then they start getting these episodes of head nods. And as I mentioned, many of these are actually in up to 60-70% of cases, most of them occur when they are eating, or sometimes spontaneously, or with a cold breeze or a cold bath, and they come in clusters. And these clusters, in a cluster, they may have up to 10, 15 episodes, and then stop for a few minutes, and then starts again until eventually the child comes out. Now, subsequently, they develop other seizure types. And it's a range of seizure types which these children have. Tonic-clonic seizures, myoclonic seizures. They have multiple drops. So really a lot of injuries, facial injuries, which you see, and some of the pictures are really difficult even to put out, sustaining a lot of injuries. They have progressive cognitive decline, really severe cognitive decline. And many of these children, the symptoms starting around, the head nods around 5 to 6, 7 years, 8, and by 8 or so years, they drop out of school, unable to cope in school. They develop drooling, increasing drooling, and speech difficulties. They are severely malnourished. They really have weights. You have teenagers with weights under 20 kilos. And then one peculiar thing which I'll be showing in photographs, they develop some peculiar lip changes with some growths in the lip. And we have taken a biopsy in one of them. This looks like more of scars. There's growth failure. Their bone age is on average 2 to 4 years behind the chronological age. And then there's a pattern of muscular dystrophy with initially peripheral muscle wasting and then increasingly more muscle wasting. Focal neurological signs are not very common. So here we have wasting initially in the palms of the legs. Once you can see severe wasting, they have very flat feet, and with it progressively develop deformities of the feet, knock knees, or abnormalities in posture, and eventually they lose mobility. You can see a child. This child is extremely short. It's an 8-year-old who just looks like a 4-year-old child. So we have proposed some form of staging, some prodromal period, then head nodding, then development of other seizures and disabilities developing over time. One thing is when you look at the face, they look like a face of a person with mitochondrial disorder, or a child who is quite depressed. And they drool quite a lot of saliva. And here below, I'm just showing some of the early lip changes. Some of them are really quite grossly abnormal. We attempted to do cognitive testing using psychological tests in 4 teenagers. And really, one completely couldn't do anything. The one 13-year-old and 2 15-year-olds did attempt to answer some of their questions, and as you can see, really their developmental age was that one of children under the age of 5 years. This 13-year-old and 2 15-year-olds on the KBC, which is one of the neuropsychological testing tools. Now, on EEG, there are quite a number of varied things. Here, this is an EEG of a 13-year-old girl. She was quite awake, did a recording for some time, but increasingly as she became sleepy, without clinical events, florid discharges, generalized discharges could be seen in some of them. Even during the head nodes, you may see this, or if now as this, the progression of the disease occurs, initially the head nodes occur alone, but increasingly later on, as the years progress, because most of the other seizure types develop 1 to 3 years after onset of the head nodding. And around that time, the child starts with the head nod, and then just within a few seconds goes either into a generalized seizure or with myoclonic seizures or focal jerking. This was an EEG which was taken earlier to try to document these head nods, and this when we demonstrated at atonia at around the occurrence of the head nods. We recently did some brain imaging, and we didn't see a lot of focal lesions in the brain. Actually, there was not a lot of changes, other than some mild atrophy. Brain MRIs we did, I think there was 7 or so who had some degree of cerebellar atrophy. Not significant. Most of it's really mild to moderate cerebellar lesions and very mild cerebral involvement. There were no focal lesions in these children. This is some of the images, and with just a bit of cerebellar atrophy. So currently what we are offering for these children is really symptomatic management. Our earlier surveys demonstrated extremely low levels of pyridoxine in this population, and so we are giving them some vitamin B, and they are on nutritional supplements, and the nutritional supplements are the UNICEF ones, so they contain a lot of trace elements and vitamins. So we are not giving other vitamins at the same time, but specifically, we are offering anti-epileptic medications. We have withdrawn the other anti-epileptic medications. We are giving sodium valproate, nursing support, and quite a bit of nutritional support. So each of the families is being given some food to try to give at home. Now, there has been this association with, and which has unfortunately to date not been confirmed with onchocerciasis. And although in amongst cases, the prevalence of onchocerciasis is really much higher than in cases, the evidence is really not very strong to demonstrate causation. The only thing which points in that direction is that on almost all of them have elevated erythrocyte sedimentation rates, and some of them really going very, very high. In this cohort of 22 children, we examined in detail, the average ESR was about, the median was 28 in the first hour. So within this area, there is a current intervention to try to control the Similian fly, the black fly, which transmits onchocerciasis. And there are rounds of mass administration of ivermectin. Now, ivermectin kills the larva, but it will not kill the female parasite which lays the larva. And you'll have to give it several times, at least up to about 10 cycles, by which time the female which lays this larva will have died naturally. And then also interventions larviciding the rivers, and aerial spraying to control the. We have opened 3 treatment centers, one each in each of these districts, and this was on the first day in one of the districts. After training health workers, we went to open this center, and there were more than 200 children who came at one go. This is in one of the most affected areas, and we are to get some people to try to create order before we could proceed. Now, the plans currently, A lot of studies are planned. There's a census which is due to start to try to map these persons where they are on GIS, to try to really look at the ecology, and also we have clinical studies, detailed clinical studies to look at it. We have a team of biologists who will be looking at these parasites and the vectors they carry, whether there have been any biologic changes, and compare it with different areas. With CDC, there are plans to conduct a clinical trial with different anticonvulsants, also with pyridoxine, and then anthropological studies and a post-mortem study, which has been quite difficult. At the end of next month, WHO and CDC are organizing a conference in Uganda to try to look at what is known as of then. As of today, I just talked to the director in charge. The screening, we have screened about 3,800 suspected people, and most of them with epilepsies, and of which 1,702 have fulfilled the criteria, the working criteria for this condition. So it's really a big population. So in summary, currently, our investigation suggests that this nodding syndrome may be a distinct neurological disorder, probably a symptomatic epilepsy, and these head nods are due to atonic seizures. We still do not know the etiology, but we think that it may be associated with Onchocerca volvulus. Our earlier toxicology screens have all been negative. Thank you.
Fascinating presentation.